Okay, so let's get started right now with talking about the topic of tractology. I tried my best to make it easy and understandable and simplified. So let's get started first of all with some rules. So here is the brain, here is the muscles and the peripheral organs. Now, when we say information is going by this little birdie from the brain to the muscles, we call it motor tracts, which are descending, they're going down. And then if some info is going from the muscles towards the brain, we call it sensory information, sensory tracts and ascending. Another thing that I want to catch up on is the gray matter and the white matter. So the white matter, it consists of myelinated nerve fibers, and these are what we call by the tracts, whereas the gray matter is consisting of the cell bodies. So here, if we take a look at this picture, the surrounding area here, we call it what? We call it the gray matter, and inside here, we call it the white matter. Now, let's talk about how to locate the legions. Now, let's say, for example, here we have tracts going up, crossing, and the remaining going up. Now, before the crossing right here, we call it ipsilateral on the same side. Whereas after the crossing, after this crossing here, it becomes contralateral on the opposite side. Now, let's get started with talking about the sensory ascending tracts. So, I divided them into tracts that cross the spinal cord and tracts that cross the brainstem. So, for crossing the spinal cord, we have something called the spinal thalamic tract. So, the spinal thalamic tract, let's talk about it first. It consists of lateral and ventral. Now, we have first order neuron and second order neuron. So the first order neuron, it consists of the dorsal root ganglion. So this is the first order neuron, we call it dorsal root ganglion. And the second order neuron, this one, the remaining one, it basically, what does it do? It immediately, as you can see here in the picture, immediately crosses the midline at the same level of the spinal cord. So this is the spinal cord, yeah? This is the first order neuron. The second order neuron immediately crosses the spinal cord and then goes and ascends up because it's called ascending, so it's sensory. Remember what we talked about in the rules. Okay, now for the lateral tracts, on the other hand, these lateral spinothalamic tracts, which we see here laterally, this is the ventral or anterior, and lateral to it a bit, we have the lateral spinothalamic tract. It's associated with the pain and temperature. Whereas the ventral tract, this one, is associated with the crude touch and pressure. Now you might ask, Noor, what is the crude touch? Crude touch is basically the non-discriminative touch, the touch that we basically say it's tactile sensation that you feel. So a person allows the person to feel that they're being touched without the ability to identify the exact location or the details. So you feel that you're getting touched, but you cannot identify the shape, the texture of the stimulus, or whatever caused the sensation. I hope it's clear. Now for the um, yeah, for the ones that cross the brainstem, we have the posterior column tracts or the dorsal column tracts. These are mainly associated with what? And this is very important to pay attention to. They're associated with the conscious proprioception and with vibration and fine discriminative touch. Now again, let's talk about the first order neuron. The first order neuron, as we can see here, this is first order neuron. It will what? It will ascend on the same side of the spinal cord and then it will cross in the medulla. So if you take a look here, it's ascending, this first order neuron, ascending on the same side of the spinal cord, and then it's going to cross right here in the medulla of the brainstem. Okay, that's why I call it cross the brainstem. So we have different types. We have the fasciculus gracilis and cuneatus. So let's start with these. So the fasciculus gracilis, where is it here? It's actually this one. The fasciculus gracilis, this one, as we can see here, it's on the medial side, so we call it the medial tract, and it's associated with sensation of the lower half of the body, so the lower limbs. Whereas the fasciculus cuneatus, this one, fasciculus cuneatus, it's more lateral, so we call it the lateral tract, and it's associated with sensation of the upper half, like the upper limbs. Okay, now let's talk about the other tracts. We have the spinocerebellar tracts. We call it for the unconscious proprioception. So basically, what does it do? From its name, it goes directly to the cerebellum for what? Unconscious proprioception, which is what? The muscle tone and the posture. So you're unconscious of your posture, unconscious of your muscle tone, obviously. Now this one here, it's divided into two. It's divided into ventral and dorsal. Okay? Okay. So the ventral, it starts with a V. So you can think of it as the V shape is side to side. So this side and this side. So what does this mean? It means that it's going to cross the spinal cord, as you can see here. So this is first order neuron, crosses the spinal cord, and then it will go up and it will cross again in the cerebellum and goes to its same side. So we cannot say it's on the contralateral. It's on the same side. Why? Because it's crossed here and then again crossed again in the cerebellum. So it goes to the same side again. The dorsal spinocerebellar tract, on the other hand, its D stand for direct. So it goes from the same side and never crosses the spinal cord. So as you can see it here, it's direct from the same side. It never crosses the spinal cord. It's from the same side. Okay? Okay, I hope it's clear for this one. Now, let's move on to the motor or the descending tracts. So this is divided into two. We have the pyramidal tracts, which are voluntary, and you have the extrapyramidal, which is involuntary. Let's start one by one. The pyramidal tract is voluntary. It's associated with the fine movement, the skillful movement, and the distal muscles. You might ask, Noor, what is the distal muscles? So the distal muscles are the ones that are located far away from the trunk of our body, like they're more closer to our hands and our feet. For example, the intrinsic hand muscles, which move our fingers, or the forearm flexors and extensors, which move our wrists, or the tibialis anterior, which lifts the foot, or the gastrocnemius, the calf muscles, which moves the ankle, and intrinsic foot muscles that flex the toes. So you get the idea. Now, these are divided into a lateral corticospinal tract and an anterior corticospinal tract. And they're called pyramidal because they form what? A pyramid shape, pyramid decussation. So starting with the lateral corticospinal, it's basically 85% of this tract, just the bulk, the majority. It crosses the lower medulla and it forms a pyramidal decussation. So looking at it right here, where is it? The lateral corticospinal, here, you can see it. It crosses the medulla, here, this is the medulla, so it crosses it and forms what? Pyramidal decussation, motor decussation. Crosses which type of medulla? The lower medulla, and then it carries on up. The other one, the anterior corticospinal, it's 15%, and it crosses before the termination. So it doesn't cross immediately. So the anterior corticospinal, it goes up and then just crosses before the termination. So it's not as important as the lateral corticospinal in crossing, because the lateral corticospinal, it crosses in the lower medulla. And this is the motor decussation, as you can see right here. Now, for the extrapyramidal tract, which is involuntary, it's associated with the muscle tone, with the reflexes, and with the balance. Now, a question comes to mind. What if a lesion happens here? What will happen? Is weakness going to appear? No. What's going to appear is involuntary movements, like Parkinson's disease. Now, we have four types of tracts. We have the vestibulospinal, which is the one that's associated with the balance and with extensor muscles. And this is very important. Pay attention to it. It can come as a keyword in the questions. And then we have the rubrospinal. So the rubrospinal is associated with the flexors. We have the reticulospinal, which is associated with the muscle tone. And we have the tectospinal. So tectospinal is associated with the visual and the auditory stimuli. And here again, it shows for you in the picture. Okay, now let's talk about the upper motor neuron lesion versus the lower motor neuron lesion. So the upper motor neuron lesion, you can think of it as like it's the opposite. In what regards to what? Upper, it affects the lower limbs. Lower affects the upper limbs. Now, the upper motor neuron lesion, if it happened above the crossing, let's say in the brain or the brainstem, it will be a contralateral lesion. So in the opposite side of your body. What if it happens below the crossing, let's say in the spinal cord? It will be in the ipsilateral side of the body. Now, what are the most important signs that we need to pay attention to? It has a spastic or rigid paralysis, like stiff body, stiff. So the body is going to be stiff. Hyperreflexia, a lot of reflexes, and positive Babinski sign, which is what? This one, the dorsiflexion of the big toe. So normally, whenever we do this, we have a normal plantar response where your toe is going to go forward like this. The Babinski sign is with your fanning of the toes, dorsiflexion of the toes. And we have slight muscle wasting, slight, pay attention. The lower motor neuron lesion, it's maybe because damage to the anterior horn cells or damage to the peripheral nerves. Now the signs here, it lead to flaccid paralysis. Flaccid means like floppy. It's not stiff. And hyporeflexia or absent reflexes, and a lot of muscle wasting. Moving on to the clinical cases that we have faced in this lecture. So we have the syringomyelia. Syringomyelia, it tells us what? It tells us we have cavitation, as you can see here in the picture. So the cavitation is happening actually in the central canal. And the central canal is going to expand outwards. And because it's expanding, it's going to affect the spinothalamic tracts. And remember, what did we explain and talk about in the spinothalamic tracts? Okay, now, since it affects the spinothalamic tracts, what will happen here is basically this person will have bilateral, means on both sides, loss of pain and temperature. So this will be like this, bilateral, loss of pain and temperature, and it will be appearing like a jacket distribution. While the fine touch with proprioception, which are associated with the dorsal column, they will be perfectly intact. This is important to pay attention to. So we have here the dilation of the central canal, as you can see. And here it tells us what? The damage crossing the fibers, it affects the anterior commissure, leading to bilateral pain and temperature senses first, and then what? Followed by crude touch and pressure. So first, pain and temperature, then crude touch and pressure, and the patient will present with burning injury on the finger, but the patient will be like, I don't feel the burn, I don't feel it, okay? Then later on, we will have what? It will affect the ventral gray horn. This is later. And when it affects the ventral gray horn, what will happen? It will be ipsilateral on the same side, lower motor neuron, weakness and wasting of the upper limb. Remember, we said lower, then it's affecting the upper limb. So again, first of all, we said it will affect the ventral spinothalamic in the anterior commissure. It will affect here the ventral spinothalamic. Okay, so the ventral spinothalamic in the anterior commissure, it will lead to a loss of the pain and temperature first, and on both sides, and then followed by crude touch and the pressure senses, and then it will affect what? The ventral gray horn, leading to ipsilateral on the same side, weakness in the upper limb, and then it will affect the lateral white column, which will lead to bilateral upper motor neuron weakness of the lower limb. So remember, the upper motor is for the lower limb, the lower motor is for the upper limb. Don't get it confused, it's easy. Just make sense out of it, okay? Okay. The second one that we're going to discuss about is the tabes dorsalis. This is what? It's a complication of syphilis or MS, multiple sclerosis. It causes selective degeneration of the posterior column tract. And remember, go back in the video to what we talked about in the posterior column tract. The patient شو رح يجي عنده? They will have sensory ataxia, and they will mainly rely on their eyes, on their vision in order to have balance. And the patient will present with falling when they wash their face or close their eyes, or falling when they're doing wudu. Okay, so look at it right here. It's affecting what? Posterior column. So this is the posterior column in the picture. So caused by syphilis or MS of the posterior column tract, it can extend to the dorsal root of the spinal nerves. Initially, severe pain because of the nerve irritation. This is the first thing, initially. So they will have loss of proprioception sensation. We call this sensory ataxia, which is falling with their eyes is closed. They also will present with what? Ipsilateral, so the same side, loss of vibration, position, and movement below the lesion. وإبسيلاترال loss of the tactile discrimination below the level of the lesion. So we have the lesion on this level. Okay, so if it's below the level, they will have loss of vibration and position movement. Above it, below the level. Oh, both of them is below the level. So excuse me for that, because I was thinking of another thing. So below the level of the lesion, just exclude that to not be confused, okay? They will present with sensory ataxia plus loss of vibration and position movement and tactile discrimination ipsilaterally. And later on, they can have loss of all sensations and loss of the tendon reflexes and hypotonia. Okay, then we have the Brown-Sequard syndrome. So we call this the spinal hemisection. Why? Because it affects the half of the spine, as you can see like this. So on the ipsilateral side, the patient will lose the motor function, which affects the corticospinal tract, and the proprioception and fine touch, which affects the dorsal column. So on the same side, they will have what? Loss of motor function and proprioception and fine touch. This is ipsilaterally. Ipsilaterally. Okay? Okay. What about contralaterally? They will use the pain and temperature, which is affected by the lateral spinothalamic, and it's basically 2 to 3 segments below the lesion. So looking at it like this, we have the anterior gray columns or nerve root. We have ipsilateral lower motor neuron paralysis and corticospinal extrapyramidal ipsilateral spastic paralysis below the level of the lesion, and fasciculus gracialis and cuneatus ipsilateral tactile discrimination and vibratory and proprioceptive sensation below the level of the lesion. So basically, I just simplified it here. It's basically better to know it from here, okay? So we could look at this picture. Loss of all sensation is present 100% here. Impaired pain and temperature, we said where is this? This is contralaterally, right? So contralaterally. And then impaired proprioception or vibration, discrimination or joint position, we said it's what? It's ipsilaterally. Okay? Okay. Yeah, so it's mainly affect the lateral spinothalamic, which leads to the contralateral, malleal pain and the temperature, anterior spinothalamic, contralateral for the touch and pressure, and then the posterior root, its entrance into the spinal cord at the level of the lesion, ipsilateral for all sensations. So again, it's a little bit complicated reading it from here, but understanding it from here would make way much more sense for solving the questions. Here also in this picture it says what? On the opposite side, loss of pain and temperature. Same side, upper motor neuron weakness or loss of position and vibration. وكمان we said what? We said proprioception, vibration, and two-point discrimination, and the joint position, all of that. So it's basically repetitive. The last thing is the anterior cord syndrome. So the anterior cord syndrome, as you can see here in the picture, it's basically damage to the anterior portion of the cord. So the patient will have what? Bilateral lower motor neuron lesion. Lower motor neuron يعني what? It affects the upper limb at the lesion level, and bilateral upper motor neuron, which affects the lower limb, below the lesion, and bilateral loss of pain and temperature and the crude touch. And we talked about what is crude touch before. Whereas the posterior column will be spared, so the tactile discrimination and the proprioception will be safe. Let's get to understand this way more. So this patient will present with what? Loss of movement, pain and temperature, but still able to feel the position and vibration and touch because we said it's preserved. So again, here it's a little bit complicated, but you can read it. That anterior gray column, it will have bilateral lower motor neuron lesion at the level, as we said, anterior corticospinal, extrapyramidal tract, bilateral upper motor neuron lesion below the lesion level, anterior lateral spinothalamic, bilateral loss of pain and temperature, and light touch sensation below the lesion level. Okay, now what I would recommend in order to be able to solve questions is to know these. These are quite high yield in order to know and like the clinical presentation of the patient. Okay, now this here, the last page, they are random slides that I thought would be important to get to know for the sake of some questions that might appear in the exam. So let's get started with them. So they tell us the level of the spinal cord lesion. Now, if it was cervical or thoracic or lumbar. Now, if it was cervical, what we will see in the upper limb and in the lower limb. So in the upper limb, sensory effects, it will be ipsilateral loss of sensation, so same side loss of sensation. The motor effect, it will be ipsilateral lower motor neuron lesion. So we said lower motor neuron lesion, it means upper limb. So both of them will be ipsilateral. In the lower limb, the sensory effect will be what? Ipsilateral, so same side, loss of proprioception or fine touch, and contralateral, pain and temperature and crude touch. The motor effect, it will be ipsilateral in the upper motor neuron lesion. So upper motor neuron يعني lower limb. Okay? So again, the cervical, we have what? The sensory is ipsilateral, and motor is ipsilateral. The lower sensory, it cuts into two. Ipsilateral for proprioception of fine touch, contralateral for pain and temperature. Motor will stay ipsilateral. The thoracic, on the other hand, the upper limb won't be affected. This is high yield. The thoracic, the upper limb won't be affected. It will be intact. The lower limb, on the other hand, again, it will be for the sensory, ipsilateral for proprioception of fine touch, contralateral for pain and temperature, crude and pressure. And again, the motor will be again ipsilateral. So it's the same. At the lumbar, again, the upper limb will be intact. And the lower limb, what differs here is that in the sensory, it will be ipsilateral. And the motor also will be ipsilateral, but it will be for lower motor neuron lesion, not upper motor neuron lesion. So it will be shown as lower motor neuron lesion signs, okay? Not as upper motor neuron lesion signs. Remember the signs that we talked about later, before, which is the flaccid paralysis, the floppy one, the reflexes, the muscle wasting, and all of that. Okay? طيب. Here, it tells us how to differentiate between cervical, thoracic, lumbar, and sacral. Cervical, very important to know that we have dorsal intermediate septum. This septum here is present. And the ventral gray horn is massive. So the gray horn that's ventral is massive, whereas the dorsal is thin. So this is dorsal and this is ventral. The ventral is way bigger than the dorsal. And the white matter will be massive compared to the gray matter. So the white matter, this white matter, is way bigger than this little bit gray matter. The thoracic, on the other hand, we have this lateral gray horn. The lumbar, we have massive ventral and dorsal gray horn compared to the white matter. So the gray matter is way bigger than the white matter. And we don't have this septum that we had in the cervical. The sacral, on the other hand, it's similar to the lumbar, but it's smaller in the diameter. Then here we have the nerve cell groups in the dorsal gray horn. So it tells us for the substantia gelatinosa, we have what? It's for pain and temperature mainly. And the nucleus proprius mainly is for crude touch and the pressure. And the nucleus dorsalis, also called Clark nucleus, is for unconscious proprioception. Okay? Okay. Here, it tells us for the lateral gray horn, so a small lateral gray projection, its cells give rise to the preganglionic autonomic fibers. Now, what's important is this one. Let's say, for example, It present in two locations. So we have the all thoracic and the first two lumbar segments, lead T1 and L2. They form sympathetic outflow. It's preganglionic sympathetic. Whereas the sacral S2, 3, 4, they form parasympathetic sacral outflow. Okay, so known as all thoracic and first lumbar. So all the thoracic from T1 until the L2 sympathetic. Is sacral parasympathetic. Here, how to identify the lesion in the CNS. So you have the brain lesions. They're mainly associated with changes in the consciousness, memory, behavior, speech, and vision. The brainstem, on the other hand, they are accompanied by what? The brainstem lesions. Ipsilaterally, cranial nerve lesion, and contralateral hemiplegia. We call it alternating hemiplegia. This term is important to know. Alternating hemiplegia. Okay? And the spinal cord lesions, this is very important also. If it was at the level of C4 or above, death here. If it was between C4 and C6, quadriplegia, which is the paralysis in four limbs, and below C8, paraplegia. Okay, and this was it. I hope it was an easy lecture. I will provide the questions to check understanding with their answers later on.